இதுதான் அங்க போய் கூட சாப்பிட்டுப்பாங்க.
Is that an AI image generated?
No, sir. I got it from internet, but not AI generated.
And we think it is HLHS.
Yes, sir.
And we have to think that it is HLHS.
Yes, sir.
Is it?
It was aesthetically pleasing, sir.
Actually inaccurate. So yesterday's presentation and day before, Shweta Pune has asked to be share the recording.
Okay, sir. We'll share, sir. Yeah, okay. Wait, then there was a something. Back up, I took one.
Start. Start, ma.
Okay, sir. Good morning, everyone. So, welcome to today's phytology class, and the topic is hypoplastic left heart syndrome. So, let's begin our discussion with the cases. So, the first case is she came to us as a second opinion for hydrops fetalis at 14 weeks and 5 days of gestation. She was gravida too. Her first baby was diagnosed with supracardiac TAPVC with severe PAH postnatally. Unfortunately, the baby expired 2 hours after the surgical correction. So this was her second pregnancy. She is in a 4-degree consanguineous marriage. So we begin our evaluation. In the beginning only, we saw that there was a extensive fluid collection, subcutaneous fluid collection. Then we began our cardiac examination. So as usual,
Spacesuit sign.
spacesuit sign it is. So we begin our cardiac evaluation with as usual with situs. So we are given the information that head is down. So from spine, if head is down from spine, if we move clockwise, this is the left. In abdomen, the stomach is on the left side. We cannot see the portal sinus clearly here, but we can assume that the abdominal situs is soletus. And in the cardiac, you can see this tiny pulmonary vein draining into atrium. So this is the left atrium, which is left of the right atrium. So from this, we can say that situs is soletus. Then we can see the heart. So see this clip nicely. This is the contractility of the heart in this patient. Let me show you a normal control at the same gestation. This is a 14-weeker, and we can see how nicely both the ventricles are contracting, coming together, as compared to this case, as compared to our case, in which this is the left ventricle. Right ventricle is contracting, but we can see that left ventricle is just riding along and not contracting as well. Then we moved on to check the fractional shortening in the left ventricle. So here we can see in the right ventricle, see how nicely it is going apart, coming together, going apart, coming together. But in the left ventricle, it's like a parallel strip going. And on measuring, the fractional shortening came as 12.5%. Then we can see on the color image that right inflow is normal, but the left is barely filling. And we can also see that valve is also not opening nicely. You can see right ventricle valve is nicely opening and closing. However, the left ventricle is barely opening and allowing any inflow. Then we went on to check the duct and we can see the reversal in it. So up till now, what we have seen that
Reversal in?
yes, reversal in the duct cell.
Is it duct?
Instead of blood flowing from the aortic and instead of blood flowing from the
This is
aortic.
pulmonary.
Yes, sir.
This is duct.
Yes, sir.
And this is
Aortic arch.
transverse arch, not
Yes,
duct.
sir. Yes, sir. So now we can see the blood is flowing towards the arch. That is, blood is flowing from the pulmonaries coming into the arch. So up till now, what we have seen is left ventricle is not contracting, right ventricle is contracting, and the blood from the pulmonary is coming in the reverse direction in the LVOT.
In, in the transverse arch.
In the transverse arch and then back. Yes, sir.
You are talking like me. Whatever comes, you are telling.
Sorry, sir.
Mm-hmm.
So then we
Yeah.
went on to evaluate further. Then we went on to do our further cardiac evaluation. We can see pulmonary was normal, RVOT was normal,
Pulmonary vein. Go back.
pulmonary veins was normal, going and draining in the atrium. RVOT was normal. Then here we can see extensive subcutaneous edema and pleural effusion. This black, this is fluid. And then here in the coronal, we can appreciate it very nicely. That spacesuit science I was talking about in the beginning, it is subcutaneous edema. So hydrops was definitely setting in. Then in here we observe that there is a thick fluid, there is a fluid collection behind the neck with multiple septations within. On further evaluation, we saw that the right kidney was normal, but the left kidney was showing hydronephrosis. Rest of the anatomy of the baby was clear. So in the finding, we gave it as hypoplastic acontractile left ventricle, functional mitral atresia, functional as in the left ventricle pressure was high, so the blood was not coming from the left atrium to left ventricle due to the, that's why it is a functional mitral atresia. Then aortic atresia, diminutive aortic arch, which was left-sided, showing a retrograde flow with bilateral mild pleural effusion. And in urogenital tract, we marked it as gross hydroureter nephrosis. So this was the summary of the finding with septated cystic hygroma, generalized subcutaneous edema, bilateral mild pleural effusion, and hypoplastic left heart syndrome with left hydronephrosis in KOB. So we counsel the patient that such a finding in early pregnancy warrant a careful and systemic evaluation of the fetus, as the chromosomal chances of chromosomal abnormality is very high, approximately 50 to 60%. So we have advised them direct fetal testing by chorionic villus sampling, and we explained it to them that the overall prognosis for this fetus is poor. We advise them if they opt to terminate, so please send the fetus for the autopsy to rule out occult anomalies. So this patient underwent amniocentesis. We requested QF-PCR, chromosomal microarray, and DNA storage from Medgenome. So here's the result of QF-PCR. We got monosomy X, that is Turner's. We confirmed it with karyotyping, and here it was concurring. Here also we got Turner's. Here is the report of the same. So we have advised the couple that as her first baby was diagnosed with supracardiac TAPVC, and the second pregnancy there was monosomy X, so we suggested a parental karyotyping, which turned out to be normal for both of the parents.
In general,
Yes,
when
sir.
you get fetal Turner,
Yes, sir.
there is no need for parental karyotyping. If it's a pure monosomy X, like a pure trisomy 21,
Okay, sir.
you don't have to do it. You can reassure that parental that the recurrence is low. But once there is a recurrence, then we need to know if there is a structural abnormality of the X chromosome.
Okay, sir.
Hmm.
So we have counseled the couple that the recurrence of Turner is very low and the chance is same as the occurrences, that is 1 in 500. However, the recurrence of cardiac problem in subsequent pregnancy is 5%. So we gave a routine counseling about folic acid administration and early anatomy scan at 12 weeks. So let's move on to our second case. So that was a first trimester case. Now this patient came to us at 24 week, 3 days of gestation as a second opinion for suspected hypoplastic left heart syndrome. So she was gravida 4. First was normal, alive and healthy baby. Second was early miscarriage. Third was unfortunate neonatal death. Baby was preterm and succumbed in view of preterm complication, and this was her fourth pregnancy. So again, we began our cardiac evaluation. So here in the situs, we are provided with the information that head is down. So spine clockwise is left. So this is left, stomach is on the left side, abdominal situs is soleus. And you can see pulmonary veins. I'm really sorry for the image. Pulmonary veins draining into the atrium. So this is left atrium, which is left of the right atrium. Hence the situs is soleus. Then we begin to see the heart. So what are we seeing? Anyone?
Nice, prominent pulmonary vein I'm seeing.
Yes, sir.
The left ventricle is not vein and the right ventricle.
Okay, exactly. So let's see this in a zoomed way. So this is normally how the ventricle should contract in second trimester. See how nicely they. in the longitudinal as well as in transverse dimension, they are coming together and contracting, both of them. However, in our case, see, this left ventricle is contracting nicely, the valve is opening nicely.
Right.
Sorry,
You.
sir. Sorry, sir. The right ventricle is contracting nicely, the valve is opening and closing nicely. However, the left ventricle is just riding along, and barely that mitral valve is opening. You can,
Jockey.
yes, sir. So then,
Normally, how do the ventricles squeeze? They squeeze towards the.
yes, sir.
Normally, how do the ventricles squeeze? Squeeze towards the.
Interventricular septum.
Correct. Yeah, proceed.
So then we applied M mode here again. So here we can see normally this is how it should be. It should come closer and then away, then come closer, then away. This is how the normal pattern is. But here, can you see there is some difference? It is a stripe, it is a parallel stripe which is going on. So from here we can say that, okay, this ventricle, this area is not contracting that much. Then we went to see inflows and we can see barely any
Hold on,
inflow.
ma. Go back to the previous image. Yeah.
Yes, sir.
Yeah. So the caliber is the M mode on the left side.
Yes, sir.
You can see the caliber of the left ventricle unaltered
Yes, sir. Yes, sir.
throughout the cardiac cycle, whereas the right ventricle expands, constricts, expands, constricts.
Sir.
There is a flat line that comes in between.
Yes,
So
sir.
this is the interventricular septum.
Yes, sir.
This is the interventricular septum. This is the tricuspid lower tension apparatus, the caudate tentinate papillary muscle.
Yes, sir.
So forget this. So only see this portion. And this is the RV wall.
Yes, sir.
Everybody clear with M mode?
Yes, sir. Yes, sir.
To get meaningful M mode for this purpose, you should have the septum
Sleeping. Sleeping, sir.
sleeping. Yeah, proceed.
Then we went on to see color. In inflow, we can see asymmetry in the inflow, barely any entry through the mitral wall. This is how it should be, symmetrical, both of them filling nicely. But here you can see comparatively it is filling, but the left one is not filling as much. Then we went
Go back.
Yes, sir.
What is that? VSD?
No, sir.
Anybody?
It is the apex formed by the right ventricles.
Excellent. Who told that?
Viveka, ma'am, sir.
Keep it up. That is right ventricle flow only. Apex is now formed by the right ventricle. The left ventricle cavity is over here itself, halfway.
Yes. Then then we went on. There was mild asymmetry in the MV and TV annulus. However, the LVOT was diminutive and very small. Here we can see this is how it should be normally, a wide, nice LVOT. But here in this, we can see left ventricle and a very narrow, thickened outflow. And if we see the Z score, see this AV annulus Z score is at -9 and this ascending aorta Z score is at -7. So it was very diminutive. Then we went, then again we went to see the arch view.
Hold on.
Yes, sir.
Go back.
Yes, sir.
Diminutive. Okay. Go to your title card.
Sorry, sir.
Title card.
Yes, sir. This, sir. Yes, sir.
What do you see?
Normal size, sir.
Hmm?
Normal size.
Hmm. The ascending aorta is shown normal. Hmm.
Yes, sir.
Okay, go back.
So again here we can see there is reversal of flow in the transverse arch. It is flowing from the pulmonary and coming back through the transverse arch. RBOT was normal and pulmonary vein we can see nicely draining into the atrium, although a bit prominent. So in the findings,
Why is it prominent?
Increased left atrial
atrial
pressure.
pressure.
Hmm. Correct.
So we gave the finding as severely impaired left ventricular contractility with asymmetry of cardiac chambers, with functional mitral valve atresia, asymmetry of atrial chambers with right atrial more than left atrium, acontractile hypoplastic left ventricle with atresia and no demonstrable flow across the aortic valve. We could see bidirectional flow through the foramen ovale and atresia of the aortic valve and retrograde flow in the aortic arch. So here again, emphasizing on the Z scores of AV annulus, it was -8, and of the ascending aorta is -6. So this was the finding of the whole case, that there is asymmetry in atria, right atrium more than left atrium, functional mitral atresia, asymmetry in ventricle with right ventricle more than left ventricle, with aortic atresia, and left-sided diminutive retrograde flow in aortic arch. So the final diagnosis was hypoplastic left heart syndrome. We counsel the
Hold
patient.
on.
Yes, sir.
Go back. One more. One more. No, one more. One more. Okay, hold on. Yeah, the left ventricle should be described as
Yes, sir.
hypoplastic,
Yes, sir.
globular,
Yes, sir.
and what about the endocardial lining? Show that.
Should have ecogenic, it should be
Show the
fibrotic.
image.
Yes, sir.
This one. Run back.
Mm.
So there is that endocardial lining, thickening and echogenic, no? So that's a bit of fibroelastosis going on. A
Yes, sir.
common association.
Yes, sir.
So you should put it as, here you should put it as small caliber
Yes, sir.
acontractile with endocardial fibroelastosis.
Yes, sir.
Hmm.
Yes, sir. So moving on to counseling, we counsel the patient that this is a major cardiac defect and it would present as a duct-dependent systemic circulation in the neonatal period. And the condition is well tolerated in utero. So this fetus should be delivered at a tertiary level center with NICU and pediatric cardiology unit. And the surgical treatment is mandatory in newborn stages and usually done in 3 stages. The surgical mortality was explained to the patient that it was very significant and the overall survival is around 70% after the end of 3 stages of the surgery. Amniocentesis may be considered to rule out chromosomal aberration and the overall long-term prognosis is poor. So this brings us to...
Go back.
Yes, sir.
The condition is well tolerated in utero.
Yes, sir.
When will it lead to high drops and demise?
It can.
Hmm?
It can be, sir.
Sir, when there is
Hmm.
small duct, sir, agenesis of duct or redundant foramen ovale.
Yeah, when the PFO and the flap valve starts becoming restrictive and starts closing, that's when HLHS can also lead to in utero demise.
Yes, sir.
Otherwise, they'll simply survive.
So this brings us to our third and last case. So she was a 30-weeker who came to us as a suspected fetal ascites. Her first baby was normal. This was her second pregnancy, and she was screen negative for trisomies, common trisomies. So when we went on to check for ascites, we can see gross fluid and bowel and liver floating in the fluid. So we concurred with the ascites. Then we went on for a routine cardiac examination, which obviously began with the ascites. As the head was down, spine left is this is the left of the spine. So stomach is on the left side and cardiac apex is also on the left side. So situs was solitus in this case. Then we went on to see the heart in detail. So here is the clip showing heart. So what we can see here is this is left ventricle. This is dilated, not contracting well, having a diminutive outflow. On measuring here, we can see very, very small AV annulus. Then we did a M mode on this, and here also we can see it was contracting, but not that well contracting. This is the left one. In the ductal, in the 3BT view, we got reversal in the transverse arch as well. DV was normal, RBOT was normal. So this was the finding of this case. The cardiac size was moderately increased with asymmetry of chamber, with grossly dilated left atrium. Right ventricle was smaller due to the compression by dilated left ventricle with severe MR and severe aortic stenosis. The ascending aorta was small caliber with antegrade flow. We demonstrated a retrograde flow in the aortic arch and diastole. Fetal Doppler shows abnormal high resistant forward flow in umbilical artery. So the oral finding we gave it as poly in Liker, asymmetry of chambers, left ventricle dilated and globular, aortic wall stenosis, severe regurg across mitral wall, and retrograde flow in aortic arch. Moderate fetal ascites, high resistance forward flow in umbilical artery, and the diagnosis is severe aortic stenosis with secondary changes in the left-sided structures. So we counsel the patient that it is a major cardiac defect that would evolve into HLHS. So this is a case which was showing you the presentation of an evolving HLHS. It was not completely HLHS. It was in the process of evolving into HLHS. We counsel them that it is HLHS, which is a duct-dependent systemic circulation in neonatal period. At present, the left ventricular function is good. However, this condition is likely to progress to critical aortic stenosis and later on, which is a precursor of HLHS. So this fetus require a close follow-up, and if identified, fetal intervention, that is fetal aortic balloon valvuloplasty, is indicated, as it has been shown to preserve the biventricular function. The procedure carries a risk of fetal demise. The normal risk of fetal demise was explained to the patient. And the long-term outcome prognosis would depend on the final outcome of the postnatal surgery. We explained that the genetic association is low, and since it is the evolving anomaly, genetic testing may be considered. And we have also did a cross consultation with a pediatric cardiologist. So these were the three cases. We have seen hypoplastic left heart syndrome in evolving gestation. First, we have seen a first trimester case. Second, we went on to see a second trimester case. And third, we saw evolving HLHS in a third trimester case. So what is HLHS? So it is a spectrum of cardiac malformation which is characterized by underdevelopment of left side of the heart with severe obstruction of left ventricular outflow as well as inflow. So the condition should be, it should have normally aligned great arteries and without a common atrioventricular junction. Moving on to epidemiology, it is a rare anomaly with 1.4 to 3.8% of all the cases of congenital heart disease. It accounts for 23% of a cardiac death occurring in first week of life. So the recurrence risk is if one child is affected, the recurrence in next pregnancy is 0.5 to 2%. However, the risk is 12 to 19% in the first degree relative of patient with HLHS. So association, do you remember any association of HLHS? Anyone? Shown's complex and Turner. Exactly. We saw in the first case, it is associated with Turner syndrome. It is associated with
Anything else?
Yes, sir.
T1318, sir.
None will be usually right-sided. 18 and 13, HLHS is not a great association.
Yes, sir.
Recently, if somebody had remembered, you had discussed.
Kabuki syndrome.
Not key.
Okay.
Williams
Kabuki.
syndrome.
Williams is usually a supravalvular stenosis. Kabuki can be associated with HLHS.
Yes.
Yeah.
So it is associated with Turner's, Kabuki's, Jacobson's, Holtorum's, trisomy 18. And one more interesting association is bicuspid aortic valves. So how it is interesting? See, bicuspid aortic valve is a very common disease. And HLHS is a very, very rare disease. So how they are associated with each other? So there is a paradox of close association of common with rare left ventricular outflow tract lesion. So for that, in an article labeled as Noble Insight into the Etiology, Genetics and Embryology of Hypoplastic Left Heart Syndrome by George C. Gabriel, they gave it as a multi-genetic etiology. There are multiple genes which are involved in the etiology of HLHS, such as NOTCH1, RBFOX2, MYH6, NKK 2.5. Are you able to hear us, sir?
Well heard. Proceed.
Yes, sir. Yes, sir. NKX 2.5, LRP2, SAP 130, PCDHA9, and it shows a variable expressibility and incomplete penetrance. So they did a research on Ohio mice, and what they found is two genes specifically, that is SAP 130 and PCDHA9 was associated. So SAP 130 gene encodes for chromatin modifying, it encodes for chromatin modifying protein, and the PCDHA9 gene encodes for protocadrin A9 cell adhesion protein. So when there is mutation in SAP 130, it leads to hypoplastic left ventricle, and when there is mutation in PCDHA9 gene, it leads to all the aortic defect phenotype. So here in HLHS, we are getting both of them. When there is just mutation in PCDHA9 gene, then it will involve all the just aortic defect phenotypes, such as bicuspid aortic valve, which is very common. But when this is associated with SAP 130, then this will lead to a cell proliferation defect, which will lead to increased apoptosis of left ventricle more than right ventricle, with metaphase arrest and activation of DNA damage response, eventually leading to hypoplastic left heart syndrome. So in early development of the heart, prior to the completion of four-chamber heart and subsequent to the closure of embryonic interventricular communication, there is abnormal development of left-sided structure, which leads to abnormal left ventricle and aorta with aortic stenosis or aortic or mitral valve stenosis, which eventually lead to reduction in flow of left-sided structure. So there is, as we all know, that cardiac development is a flow-dependent development. So there is reduction in flow of left-sided structure, which further lead to hypoplasia of left-sided structure, and the cycle continues. So this is the, I'll show you how the blood flows in an HLHS heart. This is a HLHS heart. You can see a very small hypoplastic left ventricle and a very small diminutive ascending aorta. Normally this happens in our heart. SVC and IVC bring bloods to right atrium, then right ventricle, then pulmonary, and from here it get reversed, and because left ventricle is not giving any output, so here it is reversing and coming. And in the communication between left atrium and right atrium also, as the pressure in the left atrium is more, so the blood from the foramen ovale comes through the left ventricle to the right atrium, left atrium to the right atrium. So this is an anatomical image. See, this is the mitral valve. We can see it is narrow in size. We can see pinkish left ventricular wall that is due to fibroelastosis. And this is a diminutive aortic valve. And here also we can see a very narrow ascending aorta. And then joining this is the duct. So there are two forms of HLHS. The first form in which there is atresia of both mitral and aortic valve. And there is no communication between the left atrium and the left ventricle. It leads to a severely nearly absent hypoplastic left heart. However, in the second form, there will be a patent, often dysplastic mitral valve with aortic atresia. So it will lead to a hyperechogenic globular and poorly contractile left ventricle. So why are we behind this HLHS? What is the importance of prenatal diagnosis of HLHS? As we have already discussed that it is a duct dependent disease. So we want to assess the duct as it helps in necessitating the continuous infusion of prostaglandin E1 to maintain the ductal patency in postnatal life. And we also want to assess the foramen ovale, as in case of restrictive foramen ovale or intact atrial septum, there will be a need of surgical intervention such as percutaneous balloon atrial septostomy in utero or immediately after birth. And the a detailed evaluation of left ventricle is also important, as in future it will be the dominant ventricle which will be providing blood to the fetus, to the baby.
You mean right ventricle?
Right ventricle.
Right.
So what happens in prenatal and postnatal life? In prenatally, the pulmonary vascular resistance is high. So all the blood which is going to pulmonaries eventually through duct is going to the systemic circulation. But in postnatal life, what happens is this pulmonary vascular resistance decreases. So now there is a competition between pulmonary systemic circulation and pulmonary circulation for the same amount of blood. So our goal is, postnatally, the goal is to maintain pulmonary vascular and systemic vascular resistance ratio to 1. So this brings us to the management of HLHS. Prenatally, what we can do is we can counsel the patient. Patient either they can opt to continue the pregnancy. We must educate the patient according for the 3-stage surgical repair of the baby, or if they opted for any comfort care after the birth. The patient who are choosing for 3-stage surgical approach, we should tell them the importance of close monitoring, serial fetal cardiac examination, and obstetric care in a pediatric cardiac center. We should offer them multidisciplinary counsel, and the delivery should ideally occur at around 39 weeks of gestation, unless the clinical indication are necessitating any early delivery. Coming on to postnatal management. So after birth, as we want to maintain the ductal patency, prostaglandin E1 infusion will be required. Inotropic support will be required. This all will be, Priya ma'am will be dealing with all. I'm just giving you a brief. Priya ma'am will be dealing with this in subsequent classes. The baby should be on close monitoring, and positive end expiratory pressure is provided. And the stage reconstruction, I'll give you a very brief of the stage reconstruction procedure. There are 3 steps: Norwood, Glenson, Fontaine procedure. So how is the first step is the Norwood procedure. What is the normal circulation in HLHS? Right atrium to right ventricle. Now it is going to pulmonary. Through the duct, it was going into left atrium, through the duct, and pulmonary veins to left atrium and left ventricle. And as left ventricle was not contracting at all. So what they do in Norwood procedure is they expand the size of aorta, LVOT. It was very hypoplastic in the beginning. They cut it and put a graft and expand the size of LVOT. So, and they put this LVOT over the RVOT. Like the right ventricle will be contracting and providing blood to this newly formed aorta, and the pulmonaries are joined to this aorta. So the circulation will be like right atrium, right ventricle, and this single right ventricle is providing blood to left outflow, that is aorta, and the pulmonary. But it is not good for the baby in future, because single ventricle is supplying both of them. So what we try to maintain is we want to give pulmonary a passive flow. Systemic circulation requires an active flow, but pulmonary circulation, we can give a passive flow to the pulmonary circulation. So in further Glenn and Fontaine, what we are going to do is we'll connect the inflow of the heart, that is SVC and IVC, to the pulmonary. Why to bring them into right atrium and left ventricle? We can just connect SVC and IVC to the main pulmonary, and then the right ventricle will be providing blood whole to the systemic circulation. This is the basic view. We'll be discussing this in the further classes. So what are the differential diagnosis of HLHS? The most common differential diagnosis is coarctation. But what are the difference between findings in coarctation and HLHS? That the contractility of left ventricle will be reduced in HLHS. However, it will be normal in coarctation. The echogenicity due to fibroelastosis will be more in HLHS. It will be normal in coarctation. And mitral flow will be normal in coarctation because it is coarctation is in the later stage. However, it will be absent or reduced in HLHS. Aortic valve will be patent in coarctation and will be atretic in HLHS. Other differentials are critical aortic stenosis. As we saw a case, critical aortic stenosis then evolving into HLHS. So LV is typically present in critical aortic stenosis and it will be dilated rather than hypoplastic. And how do we differentiate it from interrupted aortic arch? We had a class last week. In interrupted aortic arch, we can demonstrate a complete discontinuity of aortic arch. However, this is not so in case of HLHS. There will be a normal or mildly hypoplastic. In that case also, left ventricle was a mildly hypoplastic, but we could demonstrate a specific complete discontinuity at a level. So these are some, in our previous classes also, we were very much focused on the univentricular or biventricular outcome of fetuses in these cases. So HLHS also, we want a biventricular outcome. So we are looking for the predictors of univentricular outcome. So a study by Lindsay Edwards states that a RV to LV length ratio of more than 1.2 was the strongest variable for identifying the univentricular outcome. A similar study by Harbour et al. Conducted, which showed multiple predictors of univentricular outcome, which is bidirectional, left to right foraminoval flow, LV length Z score ratio -2.4, mitral valve length ratio -4.5. It was a predictor of univentricular outcome in 80% of the cases. This is a study conducted by...
Go back.
Yes, sir.
Okay.
This is a long-term outcome of children who survived all the surgeries in HLHS. It is a 25-year, they followed babies for 25 years. And they concluded that these children face substantial neurodevelopmental challenges as well due to complexity of physiological and medical factors. This was published in Annals of Medicine Surgery. So this was, these are my references. This was all about HLHS. Sir, any concluding remarks, sir?
Okay. So for the time being, forget the perinatal outcome, the complex surgeries and all, and go back to the prenatal diagnosis, which is key.
Yes, sir.
When we say HLHS, all these 4 letters are important, and the term cannot be used loosely for any condition where the left ventricle appears smallish.
Yes, sir.
All too often, we see people tending to use this when there is a gross asymmetry.
Yes, sir.
So, we'll take Satyalakshmi's question. What is the Z-score for LV diameter to call it hypoplasia? Satyalakshmi, like we discussed in the recent journal club, the Z-scores in fetuses are grossly unreliable when we take it as a standalone entity. So we discussed why last time. The word hypoplasia, I use it when it is small and hypocontractile. Otherwise, I put it generally as a small caliber LV.
Yes, sir.
As long as it's contracting, it can always remodel and come out if the original disease is remedied. Say, for example, coarctation and interrupted aortic arch, remodeling is possible. So the moment we put it as a hypoplastic LV, that means it is also a non-functioning LV. Therefore, I reserve it in that particular scenario. There may be difference of opinion on this, but for the fetus, we always say it is small caliber, unless we also know that it is just lost its squeezing capacity. So generally around -4 onwards, this happens, but it's not a rule. One of these cases we saw it was a nice globular. So the second case, globular LV, but it was riding like a jockey. First trimester diagnosis, lethal anomaly, parent ops termination rather than invasive. Any option for yes. Well, generally, we should discourage them strongly to go for examination of the product of conception. Why? Because according to lab reports, lab's own data, audit data, 30 to 40% of post-abortal material are of unusable quality due to maternal contamination or whatever. Because the obstetrician at that time faces the more important part of dealing with the mother's safety and completing the process correctly. So that is not a dedicated procedure to capture the fetal DNA. So always ask them to, if they are serious about it, always ask them to go for a clean procedure, which is an amnio or CVS. What are the criteria to say critical aortic stenosis has evolved into HLHS? So you should now summarize the diagnostic essentials. I've been using this word. In all conditions, you should have in your mind diagnostic essentials. When those essentials are met, then we have a diagnosis. Critical aortic stenosis, the LV size is enlarged. HLHS, it is decreased. Critical aortic stenosis, the LV is contracting or not contracting? Contracting. In HLHS, not contracting or hypocontracting. But this may be little bit this way, that way. But the most important thing is there should be no antegrade flow across
Transverse aortic valve.
aortic valve. That is the sine qua non of HLHS. Without that, you cannot put a label as HLHS. So if there is flow across, then it is not HLHS. You have to see an alternative explanation for the finding. So in critical aortic stenosis, there will be a stenotic jet still going across the aortic valve. Now you may get retrograde flow in the transverse arch. That is not any specific. You may or may not get it in critical aortic stenosis. In HLHS, it will be always there because there is no antegrade flow. All right, next. So Shilpa, those are the differentiating features between PAS and HLHS. In case of fetal birth, timing, place of delivery can change if the procedure is successful. True. Suppose we are seeing severe aortic stenosis, then we evaluate specifically. I think this was covered in the journal club meeting. We specifically ask if the LV is, if the stenosis is not mild, it should be very severe in terms of the pressure. In terms of hemodynamic, it should cause retrograde flow in the transverse arch. But it should not have evolved into hypoplasia already. So these criteria should be met. That is, it's more than severe stenosis. It is critical, but it is not yet hypoplastic LV. That is, it's not at a small non-functioning LV. So in that case, we can intervene. And as we told about in the counseling, 5 to 10% fetuses will die in experience centers during the procedure itself. But if not, then 10-year transplant-free survival, that means biventricular repair and successful outcome is about 75%. Ravi, VSD in HLHS. What is your comment, Ravi? Shivani can comment. What VSD you will get in HLHS, Shivani?
It should not be there, sir.
Yeah. So remember that for HLHS to develop,
It will come.
the septum should be intact. The corollary, if you see a proper HLHS, you don't have to go and check the septum. It will be intact. Satya, can EFE happen in first trimester? Yes, Satya. It can happen in first trimester. We have documented cases also. And remember, EFE can also happen without coarctation, without aortic valve atresia or stenosis. So it can happen as a primary pathology also. How much time will it take to change from CAS to HLHS to offer intervention on time? Okay, so this progress is not known exactly like in our Doppler abnormalities in SFGR because obviously the cases that have been reported are low. We generally watch every week if it's severe aortic stenosis but not yet there for intervention, then we watch every week. Sometimes in HLHS without fibroelastosis, there is left to right FO flapping. Does it say dismal prognosis without fibroelastosis with hypoplastic LV? Left to right flapping is what is expected in HLHS. If there is no left to right flapping, if it is getting restricted, like Vignesh has put it correctly, restricted FO, then it is a bad prognosis. Once the flap valve closes, the fetus is doomed. Even in utero, it can die. Sometimes in early phase of HLHS, there is forward flow of transverse arch. What is the pathophysiology? Then we are overcalling it. That is not at HLHS. Pooja, mitral regurgitation in LV dilated with forward flow across AV at 30 week. I think the question would be what to put it as, isn't it? So this is a typical picture of critical aortic stenosis where there will be forward flow, but because of the increased pressure, there will be mitral regurgitation. Presence of mitral regurgitation is one of the criteria required to consider for balloon-atrial septostomy. I hope that is what you are putting it under. Geetanjali,
Yes,
why
sir.
why VCAC not develop in HLHS? One of the first papers that asked the question whether HLHS and HRHS are primary pathology of the valve, like the valve gets atretic, so therefore the ventricle becomes hypertrophic and non-functional, or is it due to blood stolen away by a VCAC, therefore leading to less forward flow across the valve, and then the valve becomes atretic. One of an early paper on this by Ravi Chui was based on an HLHS fetus only, where VCAC was demonstrated in early. So this is not exclusive to HRHS. It's just less common in HLHS. We don't observe it that often. can we predict progression of critical aortic stenosis to HLHS based on T index or EA ratio alteration? I am not aware, Ravinder. If some papers are there, you can share it. Soumya, can there be a VSD in the second form of HLHS? In no form of HLHS, a VSD is plausible in the schema of the pathophysiology, Soumya. All right. So what are the diagnostic essentials, Shivani?
The left ventricle should be small in size and it should be hypocontractile.
Small caliber,
Small caliber,
hypocontractile,
hypocontractile.
LV.
LV. Then there should not be any VSD and the concordance should be maintained.
Not a part of diagnostic essential. Next.
There's no antegrade flow across the LVOT, sir.
No antegrade flow across aortic valve 2. Then retrograde
No
flow
flow.
in the transverse arch.
Yes,
So
sir.
only 3.
Transverse arch.
Okay.
Yes, sir.
Only 3. If you want to get these 3, automatically there should be aortic atresia
Yes, sir.
or mitral total atresia,
Yes, sir.
an intact septum.
Yes, sir.
So those two are not diagnostic essentials, but they will come anyway.
Yes, sir.
There's one question from Guhaprita. I think I skipped it actually. Why functional atresia when there is a small inflow on color? So it's like practically it is atresia rather than stenosis. But if you say severe stenosis, it's not. Okay, it's from Gitanjali. It's not incorrect. Okay.
So one last query, sir. When we counsel for asymmetry of cardiac chambers, where the left is less than that of the right, so when we counsel, we tell them that it can remain stable, worsen. So worst case scenario, is there any percentage that we can quote, or how do you counsel about it, sir?
Asymmetry, and then what happens? This is now at what weeks?
At 22 weeks.
22 weeks, but so generally
flow is normal.
Got it. Generally, when we see asymmetry of the ventricles, I'm sure Ritanya is going to present that. The most common reason that would evolve later is a FGR. The second most common is unexplained asymmetry. That is, there is no explanation, and post-op we have to follow. We may end up finding something like a mitral valve balloon, parachute, or a redundant foramen flap valve that sometimes we will pick it up prenatally. Then comes aortic coarctation, then comes interruption. But interruption, you should be able to exclude then and there. So whether this coarctation comes later or not is something we have to wait. So while we don't put a number to it, we check if there is evidence for fetal growth restriction now or going to come later, like a high resistance uterine. In these cases, we tell them, see, there is asymmetry, but the segmental anatomy is normal, it contracts well, and the path is clear, there is no obstruction or anything. So it needs close follow-up now and after birth, but usually it should be a good outcome. During my fellowship,
involving FGR, you will get asymmetry as early as 22, sir. For example, if the IUGR is evident at 32 weeks, we can expect asymmetry as at 22. Is that what you say, sir?
Yes.
Okay, sir.
Some slight